Right, welcome back to the deep dive. Today, we're really going to dig into what separates a good practitioner from a truly distinguished one when you're treating anxiety disorders.
hmm
Specifically, in the Australian clinical context, it's about moving beyond just, checklists and towards something more like clinical performativity.
Yeah, and our mission today, I think, is to distill what that really means.
Hmm.
What are those structural and relational skills you need to have that
That
confidence?
command presence.
Exactly. And to start, we have to think bigger about safety.
Mm.
I mean, the safe doctor isn't just about assessing for suicide or homicide risk.
Right.
It's also about psychological safety, cultural safety, and crucially, systemic safety.
Yeah.
So, using healthcare resources in the right way.
Okay, so to handle all that complexity, you need, to maintain that command presence, you need some kind of framework, right? To stop yourself from freezing up.
You do. And the sources point to this sort of flexible but rigid scaffolding. They call it the 2+6 cognitive structure.
2 minutes planning, 6 minutes interaction.
That's it. But the very first most critical step in that scaffold is what's called the diagnostic sieve.
Okay.
And before you even think about confirming anxiety, you're hunting for mimics, fatal mimics.
So this is the hierarchical approach.
It is. Level 1 is organic. You're ruling out medical catastrophes. A classic one is a pulmonary embolism. It can look exactly like a first-ever panic attack.
Wow. So you're not just screening for anxiety, you're literally screening to save a life.
You have to. You have to be aggressive. Look for palpitations, fever, anything that doesn't fit.
Okay, so we've ruled out the major medical emergencies.
Yeah.
What's the next big mimic that catches people out, especially here in Australia?
That would have to be substance use. Withdrawal, intoxication, they can perfectly mimic anxiety symptoms.
Right.
And given the comorbidities here, you had to be really thorough screening for alcohol and methamphetamine, ice.
Of course. And the final piece of that safety net, the one that's mandatory every single time.
Risk assessment.
Mm.
It is just,
Yeah.
it's non-negotiable.
And you'd use a framework for that, like TASR.
Yeah, something like TASR. Thoughts, attempts, specific plan, risk factors. You just have to cover your bases. Every single encounter.
So once that safety scaffold is solid, then we can get into the really deep stuff, like how we translate this into what's happening in the brain. The amygdala hijack and panic disorder, for instance.
This is such a great example of where the science really informs what you do right there in the room. It's a dysregulation, where the amygdala, the brain's threat center, is just hypersensitive.
And there's a good analogy for that, right?
Oh, yeah, the smoke alarm analogy. It's perfect for patients. You just tell them your alarm is hypersensitive. It's going off when you just burn toast. There's no real fire.
So clinically, when a patient is in that state, hyper-aroused, their logical brain is what?
It's offline. The prefrontal cortex is basically unreachable.
So you can't ask complex questions.
You can't. You have to use grounding techniques,
Yeah.
a calm tone, short sentences, anything to get that logical part of the brain back online first.
That makes so much sense. Okay, so if panic is a faulty smoke alarm, what's happening in OCD? When the brain's filter gets stuck.
Yeah, that's hyperactivity in the CSTC loop, the striatothalamo-cortical loop. It's like a hiccup in the brain's habit filter. It just keeps saying, check again. Are you sure, check again.
And this is where the crucial paradox comes in. Normally, you want to reassure someone who's scared. But with OCD, what's the safe strategy?
The safest thing is to actively withhold that comfort they're looking for.
So when they ask, are you sure I won't get sick?
You must not give them that certainty. Because if you do,
You're feeding the obsession.
you're completing the pathological loop.
Exactly.
Exactly. You have to teach them to tolerate the uncertainty.
Okay, let's switch gears a bit. Because knowing the science is one thing, but you have to know the system, right? Especially in Australia. Access and affordability.
System mastery. And the key there is the Better Access Initiative. It's the GP mental health treatment plan.
Which gets the patient those subsidized therapy sessions.
Up to 10 sessions per calendar year, yeah. And the management always follows a stepped care model.
So you match the intensity to the severity.
Right. For mild GAD, you might start with a digital tool like Mood Gym before you even think about face-to-face therapy.
And when it comes to prescribing, what's the critical safety check?
SafeScript. You have to check the real-time prescription monitoring before you prescribe regulated drugs like diazepam or lorazepam.
Because we're trying to avoid benzodiazepines.
If at all possible, yes. Or, only use them as a very short-term bridge, 2 to 4 weeks, max. Well, the SSRIs are starting to kick in. The addiction risk is just too high.
All right, so to pull it all together, we've talked safety structure, neuroscience, and system knowledge. What is the single most critical safety netting takeaway for our listeners?
It's all about initiating those first-line SSRIs, like sertraline or citalopram. You must warn the patient about the activation syndrome.
The possibility that their anxiety might actually get worse at first.
Exactly. That jitteriness, the agitation, it can happen in the first week or two, and they need to know it's a possibility and that it will pass.
And the final provocative thought we'll leave you with, the one that really defines a distinguished practitioner, is that safety netting also means explicitly warning patients under 25 about the small but very real increased risk of suicidal ideation during that same initiation period. They have to know to contact you immediately if that happens. Clinical excellence is about anticipating the danger before the patient even knows it's there.